My name's David Martin. I'm the Executive Director at the American Board of Orthopedic Surgery. I'm joined by four other American Board of Orthopedic Surgery staff members. Dr. Michael Bednar, who is our Associate Executive Director, Kristen Kaba, who's our Manager of Examinations, David Elstein, our Manager of Communications, and Denise Frazier, our Manager of Credentials. So what we're going to cover tonight is the Part 2 oral examination for 2026, and we'll cover the things that you need to know before you apply for that examination. So I'd like to start with the American Board of Orthopedic Surgery mission statement. This is our mission statement here, and that is to ensure the safe, ethical, and effective practice of orthopedic surgery. The ABOS maintains the highest standards for education, practice, and conduct, and we do that by maintaining those standards through examination programs, certification programs, and maintenance of certification programs. And we do that for the benefit of the public and for our patients. I would just like to remind you that as professionals in orthopedic surgery, we've been given the privilege of self-regulation, and at the board, we take that very seriously. Not all professions have been given the privilege of self-regulation, but we have, and we take that seriously, and we try and mold our programs for orthopedic surgeons by orthopedic surgeons. We've been doing that for 90 years. One of my predecessors, Paul DeRosa, wrote the book in the lower right corner when he left the board, and he titled that 75 Years of Doing the Right Thing. And that's what we try and do at the ABOS. We try and do the right thing. I'd also like to focus on one of our guiding principles, and that's listed here. We have several guiding principles that you can find on our website, but this one's important. We believe there's no place for bias or discrimination within the field of orthopedic surgery or within our organization. And we have really invested in that guiding principle. We have a standing committee at the ABOS on diversity, equity, inclusion, and we have had an outside organization evaluate our board and all of our processes and our staff in those areas and make recommendations that we are currently acting on. I show you this picture for a couple reasons. This is our board of directors. We have a national board of directors made up of 20 orthopedic surgeons and one public member. That group of people sets our direction, sets our strategic plan, and implements our programs and processes. They're supported by our full-time staff in Chapel Hill. I also show you this to let you know that this is a group of practicing orthopedic surgeons who serve on a voluntary basis, and they go through the same board certification processes as you and I. These are the initial certification dates and the recertification dates for our board members, and it also includes subspecialty certification in either surgery of the hand or sports medicine. This is a group of people who cares a lot about board certification, and I assure you that you could contact any one of these individuals to discuss our programs and processes, and they'd be happy to do that. So what we'll cover tonight, just by way of overview, we'll cover the board certification requirements, what requirements you need to have to sit for our examinations. We'll also cover the nuts and bolts of the application and the application process. We'll talk about the case list that you've either already started to submit or will begin to submit soon. We'll talk about the patient-reported outcomes program that goes along with that case list. In addition, we'll answer your questions. If you have a question, go ahead and raise your hand in Zoom. We will unmute you and call on you, and you can ask your question. Once your question is answered, please lower your hand. And if you have a question that's answered by someone else or asked by someone else and answered, please go ahead and lower your hand, and we'll try to get to as many questions as we can tonight. So the 2026 ABOS Part 2 oral examination, preparation for that consists of 4 parts. The first is meeting the requirements. The second is submitting a case list. Along with that case list, you'll complete an ABOS Part 2 examination application, and you'll submit the application fee. All of those documents and fees are going to be submitted through your ABOS dashboard, and you find that by going to our website at abos.org and log in with your unique username and password. So, what are the requirements? Well, the requirement is you must take the Part 2 oral examination within 5 years of passing the ABOS Part 1 examination. Once you pass the ABOS Part 1 examination, you become board eligible. Usually that's a period of 5 years. It can be more than that if you complete a fellowship during that time period. So you must take the ABOS Part 2 exam while you're board eligible. That's generally within 5 or 6 years of passing the Part 1 examination. You must have a full and unrestricted license to practice medicine in the United States or Canada. That's not a requirement. A state medical license is not a requirement if you're engaged in full-time practice with the federal government. You must start practice and have hospital admitting and surgical privileges. You had to have had that starting on November 1 of this year, November 1, 2024. And you must be continuously and actively engaged in the practice of operative orthopedic surgery, other than as a resident or fellow, in one location for at least 17 consecutive full calendar months. And that's from that November 1 date through March 31, 2026. So you must have hospital admitting and surgical privileges and be in practice from that November 1 date through March 31, 2026. That's the year that you'll take the oral examination. So that your hospital and practice affiliations must be the same during that 17-month time period, and you have to have full hospital admitting and surgical privileges during that 17-month time period. As far as submitting a case list, you will submit a case list for the first 6 months of 2025. So you enter all surgical cases from January 1 to June 30 of 2025, okay, starting in about 3 weeks. You enter cases where you're the primary surgeon. Do not enter cases where you serve as a co-surgeon or where you serve as an assistant surgeon. So don't enter cases where you're listed as a co-surgeon, and don't enter cases where you're an assistant surgeon. If you are the primary surgeon, generally that's dictating the operative note, those are the cases you include. There are surgical cases. We have a definition for surgical cases that's on our website, and there's a list of procedures that you should not include listed on our website by CPT code, and that's found on, again, on our website at abos.org. It will ask for a medical record number when you submit those cases. That's the hospital or surgery center medical record number. Now, if it doesn't assign a medical record number until the date of the surgery, that sometimes happens, you can use your chart number initially and then change to that medical record number once that becomes available, because you'll enter cases as they're scheduled so that we can obtain patient-reported outcomes. We'll talk about that in a minute. If you're away from practice for 14 or more consecutive days during that case collection period for any reason, life event, vacation, whatever it is, we will back up your case collection period to December 1st. If you're not engaged in active surgical practice for more than 30 consecutive days during that case collection period, so if you're not going to perform a surgery for 30 days during that case collection period, please contact the ABOS office as that happens, and we can give you further instructions based on that situation. Your cases are submitted through your ABOS dashboard. Again, you get there at our website through your unique login and password. You can find detailed instructions if you go to your dashboard, and there's an information packet that's entitled Information Packet Preparing Your Case List. There are also a number of instructional videos on our website as well. So why do we get a case list? Many people ask, why is a case list important? Well, we use that as a great way to assess a candidate's practice. It's an opportunity for you to do a self-evaluation of your performance in practice by looking back at 6 months of your cases. We also give you a case list feedback report. Part of that feedback report and what that looks like is on the right side of this slide. It compares you to other Part 2 candidates in general orthopedics, and if that's your subspecialty or whatever your subspecialty may be. And then it also compares you to all Part 2 candidates, and it looks at how many cases you did, what your top 3 ICD codes were, your top 3 CPT codes, and so on and so forth. In addition, the case list is the basis for cases that you'll be examined on in the Part 2 oral examination. So we use that case list to choose the 12 selected cases that we'll use for the examination. So patient-reported outcomes. We collect patient-reported outcomes for all surgeries performed during that collection period. So what you want to do is enter the case information at the time you schedule the surgery. So you should start now if you're starting to schedule surgeries in January. Information can be entered for those cases by a staff member, and you basically enter a small amount of information and then also enter the patient's email address. We have communication templates for your patients in that packet that you can copy and utilize to send to your patients so that they will understand why we're obtaining patient-reported outcomes. We will also, once we get that email, we send patient-reported outcomes in physical function and pain interference at pre-op time frame, at 6-month follow-up, and at 1-year follow-up. The questions in that, those are PROMIS, case-reported outcomes, patient-reported outcomes, excuse me, and those questions vary depending on the patient response and depending on the surgical site. It's available in English and Spanish. If you'd like to see how that works, you can register yourself as a patient with a case, and then you'll get the survey in the mail and you can see what that looks like. Just remember to delete that before you finalize your case list. Finally, that outcome information is utilized by our credentials committee, and we also provide you with a report on your patient-reported outcomes. And this is one of those screens from those patient-reported outcomes, and it's a live site that you can get to through your dashboard, and that gives you physical function and pain interference for all of your cases, and you can break that down on various screens. So this is what that initial entry screen looks like. You can see that it's a patient registration. The hospital or surgery center, you can enter a number of surgery centers or hospital locations, and you'll click that down arrow, and you can enter which hospital it is. Again, you enter the medical record number, patient initials, age, patient sex, if the patient prefers Spanish, the date of surgery. We want a short description of the surgery, okay? That's like left total hip replacement, right carpal tunnel release, left knee arthroscopy with medial meniscal, with partial medial meniscectomy. We don't need a whole book written there. You don't have to use the whole 100 characters. There's a drop down for what section of the anatomy it is. If the patient opts out of giving an email, you click that box. Otherwise, you enter their email, confirm that, and then you can submit that, and that starts the case list for that patient. Once you go to the rest of that case list, these are the fields that you'll see there. Again, the patient initials and ID will already be there. The gender will be there. The age will be there. You'll enter the date of surgery, right? Your date of last follow-up, ICD codes, CPT codes, anatomic region, and then we don't need, again, a lot of history there, but you'll have the opportunity to change that description of the operation. So that's the case list. We can answer any questions about that at the end. We'll go to the application. The application is available now. You can get to that again through your dashboard. The application and the completed case list are due August 15, 2025 at 4 p.m. Okay. And we'll talk about that with submitting the fees as well, but you don't want to wait until the morning of August 15th to start entering this information, okay? The application requests various information that you'll find on other application, but there's a few special notes that we should go over. For each practice location that you've been in since the time that you passed Part 1, you'll need to enter that practice location with your partner's names and emails. There's a limit to that, and you limit it to the partners that you're most familiar with, and the number, I believe, is 12 of your closest partners. And you pick the 12 that are closely associated with your practice, if you have more than 12, and you enter their email. For every hospital or surgery center where you have admitting and surgical privileges, that needs to be verified by a current letter indicating your original appointment date and the type of appointment that you have. Not the initial appointment letter that you got when you started there, but we need a current letter. So you need to go to the hospital and say, I need a current letter that says my original appointment date and the type of my appointment, what type of privileges that you have. In addition, for each of those areas, for each hospital and each surgery center, we need names and emails for the individuals listed here: chiefs of staff, chief of surgery, orthopedics, emergency medicine, radiology, anesthesiology, the head of orthopedic nursing, and the OR nursing supervisor. So any of those hospitals or surgery centers that has those individuals, we need their name and their email. In addition, for each state medical license that you have, we need the date that you were conferred that medical license and the license number for each state. In addition, there'll be a drop-down menu, and we will ask for our peer review program for the names of 5 ABOS diplomates in your practice area that are familiar with your practice. And you will choose those. There'll be ABOS diplomates, and they'll be in the drop-down menu. So what do we do with our peer review program? Well, the peer review program is a comprehensive 360-degree peer review process. It's important for our credentials committee to review that peer review to allow you to sit for the examination. Each of those individuals that are listed on your application will use those emails to send them an email that asks them, if they're familiar with your practice, to fill out a peer review survey. It contains questions related to your patient care, surgical skills, professionalism, and communication skills. Again, we use the names on your application. We also use a zip code list of individuals who are in practice in your area, and we use sort of concentric circles around the zip code of your practice to identify individuals in that way, and we also send peer review surveys to them. What are the costs and expenses? The application fee is $975 if you submit that by 4 p.m. Eastern Time on August 15, 2025. That you need to submit the application fee, the application, and your case list. They have to be finalized on that particular day. The late fee of $500 adds to the $975 if you want to take advantage of 2 additional weeks. That occurs on August 31st, 2025, so 2 weeks later. That will incur an additional fee of $500. So if you want to take advantage of the additional 2 weeks, that's $975 plus the $500 late fee. Then the examination fee will be $1,350. That will be due in June of 2026 once you complete your uploads of your documents and images for the examination. So let's talk a little bit about that case upload. So once we get that application submitted, again, by August 15th, August 31st, we will start the credentialing process. We obtain the peer review. Your case list goes through an algorithm that reviews all the case lists, puts all the cases together, and then reviews and looks for outliers. Our credentials committee reviews all that, and decisions are made in March as to who's approved to sit for the examination. In April of 2026, if you're approved, you'll receive a list of 12 selected cases. So we'll use your case list, choose 12 selected cases, and you'll be responsible for presenting those at the time of the oral examination. Once you receive that list, you'll begin the upload process of uploading the required documents and images. There will be an information packet that will be available on your ABOS dashboard that will tell you what to upload and what not to upload, and take you through the process of how you go through that upload process to get your documents and images uploaded onto the site. On the day of the examination, okay, we will send you specific email instructions as to where and when to meet. Everything you submitted for those 12 selected cases will be available on the computer that you'll use to take the examination, and you'll be examined in 4 sessions, 25 minutes each, and there'll be 5 minutes of break time in between each session. In each of those 25-minute sessions, two examiners will ask you questions about three cases. The order of cases will be exactly as they are, cases 1 through 12. In the first session, they'll go through cases 1, 2, and 3. Second session, cases 4, 5, 6, and so forth. Just some friendly advice. On the day of the examination, you want to arrive early. We'll indicate where you report and when you report. I would consider arriving a day early to be sure, to make sure you don't run into travel issues. The examination generally takes place in the summer, but travel can be an issue. I would encourage you to dress in professional attire. The examiners will certainly do that. And so consider arriving early, both on that day and perhaps even a day before, depending on the amount of travel that you have in between where you are and where you need to get to for the examination. So, how is the examination scored? This is something to consider as you upload information and as you prepare to present the cases. You'll be scored in 9 different areas, 9 facets that are contained on the scoring rubric. This scoring rubric's on our website. You click on it, it becomes a PDF. You can download it. They use the scoring rubric. The examiners don't look at you and go, this person ought to pass, this person ought to fail. They score the 3 cases that are in front of them during that session. And the scoring rubric is fairly tight. You'll be scored on each of these 9 areas for each case, a 0, a 1, a 2, or a 3. Those words that are on the scoring rubric appear to the examiners when they hover over that score on their score sheet. So they're graded by psychometricians then. We take into account their consistency, their severity, their leniency, to make sure that you receive a fair examination and the scores are adjusted in each of those areas. And as far as preparing, there are videos that you can look at on our website that will help you in the upload process, that will help you prepare for the examination. The scoring rubric is available. Those are available on our website. There will also be uploaded a preview of the examination that will be uploaded to your dashboard in 2026 after we give you your 12 selected cases. And so it will be critical to watch all of those videos and really take all that information to heart. I would encourage you to upload the documents yourself, upload them early, and practice based on how you upload the documents. We'll talk about that in a minute. If you gather all your documents and images and wait till the last day and say, okay, I'm ready to upload, you won't make it. That's just a word to the wise. We do have accommodations, ADA accommodations, breastfeeding candidates, candidates for our alternate date examination who may have a life event around the examination date in July. More information about that, request forms for each of those areas are available on our website. If you have any questions, don't hesitate to call. Okay, so just some hints as you roll into the upload process. Be honest as you upload your cases. Everyone has complications. We get far more excited about someone who says, oh yeah, I did 6 months of cases and I had 0 complications, than we do about someone who perhaps may over-report complications. You should be prepared to talk about the complications, explain how you tried to avoid complications on each case and why they occurred if they occurred. Follow-up of these patients is important. So you want to try and get patients in for follow-up. If you're unable to get patient follow-up, you want to be ready to explain how and why you attempt to get follow-up on your patients. I would encourage you to practice your presentations with colleagues who will be critical in looking at your cases and who will use the scoring rubric while reviewing your case presentation. It is not helpful to say to one of your partners, hey, I'm going to present this total hip. Oh yeah, you'll do fine with that. That's not useful information for you. You need someone to sit down with the scoring rubric and go right through those 9 facets with you, look at each case. Follow the information packets very carefully. You just received one. You'll receive one next spring that will help you with the upload process. Informed consent is important to our examiners. Be sure you upload the informed consent for each of the 12 selected cases. Clearly, you don't want to argue with the examiners. Don't expect to receive feedback from the examiners. They're instructed to score you, not to educate you. So they will ask questions, listen to your answer, and move on. They will move quickly through that process. As far as the process goes, enter the patient-reported outcomes information at the time the surgery is scheduled. Once the surgery is performed, you can work on the other aspects of the case list section, those other sections of the case list. Submit your case list and application, pay the application fee through your ABOS dashboard. Again, the deadline is August 15th. The late deadline is August 31st. That'll cost an additional $500. We obtain peer review and review your case list. We start that process on August 15th. That's why we charge a late fee, because we start processing those applications. There are 900 to go through, and we need to do that in a routine fashion. In April of 26, the Credentials Committee meets early April. They review all of that information, and then you'll receive an email as to whether or not you're approved to sit for the examination. Once you get that email, if you're approved to sit, you'll receive a list of the 12 selected cases you're responsible for presenting. You will upload the required documents by June of 2026. There's a video on the website that outlines how you upload those documents. Again, there'll be a deadline in June of 26. If you wait until the day of the deadline to upload all your documents, you won't finish. Okay, once you upload the documents and put those in order, you have to create an electronic medical record. That takes time. Okay, you don't want to leave it until the last day, and you may have an unstable internet connection, and once the deadline occurs, you can't upload any more documents. You'll pay the examination fee once you finalize all those case uploads. That's another step in the process. So you finalize your case uploads. You create 12 electronic medical records and look at those. Make sure the documents are in the order you want them. Make sure the x-rays in the order you want them. And then you have to pay the examination fee. If you wait until the last day, you won't finish. You'll then, so that's just a word to the wise. If you wait until the last day to start uploading, you won't finish. Take the ABOS oral examination in July of 2026. Your specific date and time will be emailed sometime as soon as we can get there in June of 2026. And then in September of 2026, early September, you'll receive an email that will have a link to your examination results. Please keep us updated throughout your career with your contact information. The email address is the most critical part. We communicate by email. If you don't update your email, you will miss things and your board certification will be in peril. Again, please keep your email updated throughout your career. That's an incredibly important point. We communicate by email. We spend a lot of time when we send you an email, it's specifically for you. We do not send blanket emails to everyone. When you get an email from the American Board of Orthopedic Surgery, you need to read it because it has information that's specifically for you. Throughout your career, you'll be assigned a certification specialist based on the first letter of your last name. When you call the American Board of Orthopedic Surgery, if it's during our hours from 8:30 to 4:30 on weekdays, someone should answer the phone. And you'll be directed to one of these individuals if they're available. You can also email them. You can also call and ask to talk to me or email me. I'm dmartin@abos.org. Don't be the Tyrannosaurus Rex and miss deadlines. If you keep your email up to date, we will send you information about how to become board certified and maintain that certification. On our website are a lot of important informations and links that can help you. This is one. You can also go there directly, abosroadmap.org. It starts from the beginning of residency, starts at PGY1, and takes you all the way through to retirement. This is the front page of that website. And if you're a resident, you click on residency, initial board examination, click there, maintenance, you'll click on that box and you'll get all kinds of information that will help you obtain board certification and keep it throughout your career. We're active on social media. We have obviously our website at abos.org. We have a patient-facing website that you can give to your patients that tells them what process you go through to become board certified. That's mycertifiedorthopedicsurgeon.org. We're also active in these areas of social media. You can follow us there. In addition, I would recommend highly our podcast. It's hosted by David Elstein, who's with us tonight, but there are podcasts there not only of orthopedic leaders and orthopedic giants that talk about their career, but also from people who give the Part 1 examination, people who have taken the Part 1 or 2 examination and been successful, people who give tips on how to pass the Part 2 oral examination. So if you go to anchor.fm/ABOS or wherever you get your podcasts, you can find a list of those podcasts, and they can be very helpful. That's the end of my prepared comments and our slide deck. If you would like to ask questions, I see that several individuals have already raised their hand, and we'll try and get through as many of those tonight as possible. If you know someone who's missed this webinar or you want to view it again, it will be posted tomorrow on our website, also on YouTube, and on our podcast, we'll post an audio-only version. So I'm going to go ahead and stop sharing my screen, and we'll begin to answer as many questions as we have time for.
So let's start with Dr. Perez. You see a thing on your screen, unmute.
Hey, how's it going, guys? Yeah, my question is regarding assist. Does it affect you at all if an attending surgeon functions as one of your assists? I know there was a slide and a bullet point discussing the type of assist that you have and whether you could be a co-surgeon or not.
We don't want you to include cases where you're a co-surgeon. But if you're the primary surgeon and dictate the operative note, it's fine to be assisted by another board certified orthopedic surgeon or another board eligible orthopedic surgeon. As you upload cases, you need to remember that those are cases that could be chosen for you to present at the time of the oral examination. And so if a case is chosen, then you don't want to have to call and say, oh, I was a co-surgeon on that case. That will not present well at the time of the oral exam. So that's where that comes from.
Dr. Wynn.
Hi, thank you very much. I had a quick question regarding the PRO. So I'm particularly, I'm in a trauma practice, and I wondered if obtaining an email preoperatively or perioperatively can be a little bit difficult. Is there a time when it is no longer useful from your standpoint to enter that? Is it within a week, or how would you suggest that be navigated?
Sure. That's a great question. For trauma patients, obviously it's a little bit difficult to get that preoperatively in many cases. But within the first several weeks, if you supply that information, what the Promise Health Organization has looked at that, and generally patients can estimate their pain and physical function prior to their traumatic experience. And so within a couple weeks, if you can get that information, that would be great. That would be very helpful.
Thank you.
Dr. Polachek.
Yes, thank you. If we receive privileges at an additional hospital or surgery center after November 1st or during board collection, does that invalidate our ability to take boards this cycle?
No, I'm going to watch Denise Frazier as I answer this question, but no. You do have to have hospital, not surgery center, hospital admitting and surgical privileges as of November 1. And that at least one of those has to last the entire 17-month period. You can add hospitals to that or surgery centers to that. You can also drop a hospital, but there has to be at least one hospital that you have privileges, admitting and surgical privileges the entire time.
And then a second question, if we are in practice and doing clinic, not taking vacation, but do not do a case for 14 days during board collection, does that then backdate us to December?
Again, I'm looking at Denise to make sure. No, as long as you're practicing and engaged in your practice, that would not count as 14 days away from practice.
Okay, thank you.
Dr. Eakin?
Yes, sir. Thanks for everybody's time tonight. I have two quick questions. One regarding the CPT codes. I understand we put those into the scribe system. Is it important that those codes match codes in our operative report? Just for example, my hospital specifically asks us not to put CPT codes in our operative reports so that the billers and coders can kind of look at them after the fact.
So they do not have to be in your operative note. You know, we're interested in the CPT codes of the case that you did. So I would yeah, that depends on your practice, and we would not ask you to change your practice. So if you know, our hospital's different from yours. My hospital says put all the CPT codes in there, and then we'll sort them out, and the coders will sort them out once they get there. So if you looked at my notes, there'd be a whole bunch of CPT codes, and then the biller say, you know, these are the ones that we're going to include in the bill. So I just think you just have to be ready to explain that.
Yes,
But we're
sir.
interested in the CPT codes of the case that you did primarily. You know,
Yes,
that's
sir.
yeah.
Great. And then the second question was regarding the state medical licenses. I understand you want all state medical licenses that we currently hold. That includes ones that we held during residency and fellowship, even if we have not practiced in those states during this board collection
Yes.
period.
Yes.
Okay. That's it. Thank you.
Great. Good questions. Thanks.
Dr. Wester?
Yeah, hey, thanks for all the information. Just a quick question. So I was just notified that I'll be going on military leave for 3 weeks in April. So I will not be in my practice during that time. Does that mean that technically my collection period will now roll back to December 1st?
Yes,
Yes.
that's correct.
Okay, so then I just need for those these patients over the last 8 days or so. I won't necessarily have pre-operative. I just wasn't expecting that. So I'll just same thing, collect the information, but may not necessarily have the pre-operative.
Yes. Yeah, that would be fine.
Okay.
Yes. Yeah, that's fine.
Okay. Thank you.
And then Denise, if he contacts our offices to get the case list.
I've already taken care of it. I just took care of it right now.
Okay, well, there you go. You just
Excellent. Thank you.
contacted our office and we took care of it.
Okay. Thank you.
That's where we roll. Next up, Dr. Mathewson?
Hey there, a couple just mini questions, but finagly questions. Number one, you sent out the pre-operative patient-reported outcome. Sometimes, you know, especially being new in practice, the time from signing a patient up for surgery to actually getting the surgery can be pretty short, and patients at times can be historically unreliable. What if you're not able to get a hold of them, or if they don't fill out the patient-reported outcome? I know we try our best, but is that just kind of a toss-up?
Yeah, we would like you to make every effort to include their email there, and let them know. And they're surprisingly good at filling those out. Yeah, if they get it, the response rate has been really good. And I would just say more often than not, patients either call or email and say, if you know anything about the promise, the way the questions are written, the patients call and say, you didn't give me a good enough opportunity to tell you how good Dr. Mathewson was. So it's not, it's not something I would worry about. And it gets you good information, is, you know, one of the reasons to do that, that we give you back all that information so you can look at that.
Okay, and then second quick question, kind of just a bit of a gray area, but if, say, for example, I have my own practice and I contract out to a group, I'm not necessarily, you know, that's not my only sole practice. As long as I have those affiliations with the group since before November 1st, is that okay? Because I've had my own practice since before working with that group.
Yes, that sounds okay.
Okay,
No
just wanted to
trouble
make
with
sure.
that, but yeah, that sounds okay. Denise, that sound okay? Yeah, yes.
Just because when I was looking at it, I was going, for your practice, I'm going, well, I'm the sole member of my practice, but I contract out to a group that has multiple members. So then I could use them as the current members of your, you know, quote unquote practice.
Yes, yeah, that's correct.
You would list both practices in your application and you would collect cases from both practices.
Thank you.
Okay, just to let everyone know, we have a lot of people in line, so doesn't mean we're ignoring you. Next up is Dr. Girdler.
Hi there. Two questions. So you mentioned to upload informed
Hey,
consent.
answer one.
Is that the surgical informed consent or any other type of consent?
No, that's a surgical informed consent. It's just a commonly missed document in the upload process. And you really, as you go through those uploads, you really want to be careful as you upload things, that the proper informed consent gets to the proper patient's site. That it's something to start early and pay real close attention to as you upload those documents, and you can then look at what those documents look like and what the examiners will see on that platform. That's important.
Got it. And then the second question is back to the co-surgeon. So the packet that was sent out mentioned a special situation where, I mean, I'm a spine surgeon and I operate with a neurosurgeon, and I independently dictate my own report, but don't have preoperative or postoperative follow-up for those co-surgeon cases. Would those need to be included?
Yes, if you're the only orthopedic surgeon in the room, you do list that case.
Okay. Thank you.
You're welcome.
Next up is Dr. Krotler. Sorry if I mispronounced your name.
Oh, all good. Thanks for having us this evening. For the consent form for sharing of PHI, is that an official form on the website?
So, I'm sorry, go ahead, Denise.
There's a sample of that in the information packet. You don't have to use that, but there is a sample of it.
Okay,
We
and that is
Yeah, we don't need that form. If the patient in some way gives you permission to not redact the PHI, we just need you to tell us you have permission from the patient. But there's a sample form there. Various institutions may have a different version of that form, but that's there's a sample form on the website. So you can either redact or get permission from the patient so that you don't have to. And if you say, I got permission from the patients, I don't have to do that. That's what we need.
and
We don't
that's
need
just for
form.
the 12 selected cases, correct?
Yes, for the 12 selected cases. That's correct.
Okay, thank you.
Next up is Dr. Hashem.
Hi there. Thanks so much for your time. Just to echo some of the one of the questions earlier, I'm a trauma surgeon with like a really heavily marginalized, we'll say, population where I have, upwards of 30 to 50% people who don't show up to follow up, don't speak English, or don't or otherwise are not capable of essentially participating. So just what have you guys done in the past for essentially that high attrition rate for people in that type of practice?
Generally, we evaluate the case list. And so if you saw there's a place, again, on the case list upload document where you list follow-up. And so if there's not follow-up, that case is generally not one that we would tend to choose more often than not. If there are no cases with follow-up, those cases may get chosen, and then they're presented, you know, as they are with the follow-up that you have.
Fair enough. Thank you very much.
Dr. Gosi? Go ahead, Dr. Gosi Gregory. Is that?
There you are.
Try again.
Are you there?
We do not hear you. I'm not sure if your microphone is not hooked up, but everything looks right on our end. We will go on to the next person. Just keep you up and we'll see what happens. Dr. Shahi, sorry if mispronounced.
That's perfect. Thank you very much for your time. I have two questions. One was in line with what was asked before for call patients and trauma patients. You know, oftentimes there's a hip fracture that you see and you operate on the same day. In terms of prompts, is it okay that essentially you are submitting the case and the prompt for preoperative is going to be asked after the procedure?
Yes. Again, if you can do it as you schedule the patient preoperatively, that's best. But if you have a hip fracture and just meet the patient on the day of surgery, if you get that information in the ensuing couple weeks, if you submit that, then generally what the Promise Health Organization has found is that they can send out the preoperative survey and actually get pretty good information. Patients can pretty well, trauma patients do, most of them do pretty well at estimating where they were with pain interference and physical function prior
Gotcha.
to their traumatic event.
So the second question is that, is there a guideline by the ABOS that shows what is the sufficient follow-up visits, like the increments?
No, we would like for you to follow up your patients as you would in your practice. So that's you know, the evaluation. We don't have specific guidelines. I mean, you know, we
Okay.
yeah, allow people, we would like for people not to have to change their practice, but rather to evaluate their practice you know, as they generally perform.
I see. Thank you.
Next up, Dr. Sedikatapur. Was I close at all?
That was close. Not as good as some others, but that was pretty close. Thanks for trying. I appreciate
Close enough. It's fine. It's horseshoes.
I had a couple of questions. Number one was, what if you have no partners?
So then at that, in the application, you would not list any partners. I mean, you list partners that you have up to the 12 closest partners that you have in your practice. So if there are none, there are none. That's
Okay.
fine. Yeah.
And for patient-reported outcomes, I know you guys mentioned that you had English or Spanish. What do we do about other language barriers?
So if there's another language barrier that we don't have a good solution for at this point, so that would be someone who would opt out.
All right, thank you.
No problem.
It helps if I mute myself. Dr. Parham.
Yeah, I just have one quick question. So I have a kind of a split appointment with an academic center and then at a VA facility. And unfortunately, the VA said facility, instead of having an MRN, they just use everybody's social security number. What is the appropriate MRN to use for those patients?
The last four of their social security number is what you use.
Okay, that's what they use in the system. I didn't know if that was okay with you all. Okay, thank you.
Well,
Dr. Jones? Go ahead, Jeremy Jones.
Okay, perfect. So I have a question. I'm currently credentialed at two different hospitals. One of the hospitals I was credentialed prior to November 1st, and the other one I got credentialed after November 1st. So do I have to do most of my cases at the hospital I was credentialed in prior to the November 1st deadline?
No, you just have to maintain those hospital admitting and surgical privileges through March 31st of 2026.
Okay, thank you. And the other question with the peer review, the 5 people that you have to kind of are that in your community, do you choose that? Or do you guys kind of just figure that out based off your zip code?
No, you have the opportunity to choose 5. You will choose 5 individuals, 5 ABOS board certified individuals from a drop-down list.
Okay, thank you.
Dr. Cuso?
Hi, good evening. Thanks, everybody. I had a question. You had mentioned including all of the contact information for your partners or colleagues since you became ABOS eligible, I think was the language you had used. So as a fellow, I was credentialed as an attending. And so should I include contact information for people in fellowship or just at my new attending position?
Practice, only in practice, not fellowship.
Okay, thank you.
Dr. Strzezuski?
Hi, thank you, everyone. Quick question. So, a few of the surgery centers that I work at don't have a mechanism for uploading intraoperative fluoroscopy to a PACS system. A get around this has been using a Haiku feature to directly upload a picture of the fluoro into the medical record. Is that adequate, or is there any additional documentation that's needed?
I would leave that up to you and say what we need is information that you would use to present the case. So if you're presenting the case to one of your partners, if those images are reasonable, then I think that's fine. You would be presenting the case to another orthopedic surgeon. So
Okay.
what images you think they would want to see, I think are the most important.
Okay, great. I was just
don't know.
clarifying whether it was satisfactory to pull that from like a media tab within the MRN versus like a PAC system.
Mike, I don't know, maybe you have a comment on that. I mean, I think that's fine as long as the image shows what you want it to show. You'd be presenting the case to 2 orthopedic surgeons.
I think that's right. It's really dependent upon the quality of the image that you get. If the quality is good enough in your electronic medical record that the details of the surgery, healing of the fracture is adequately visualized, same as you would do if you were defending that case in court, then it's reasonable. If it's not, because the image quality is poor, then you need another way, just in general, of being able to save those images.
Understood. Thank you.
Dr. Igboechi?
Good evening. 2 questions. I have a pediatric practice. So I'm assuming the emails that I'll be collecting for most patients will be the parents, not directly to the patient, correct?
Yes, that works.
And then for some of my cases, particularly the spine cases, I'm booking them, 3 to 4 months in advance. So when you say that the patient reported outcomes are collected at time of scheduling, is that at that clinic visit, even though the surgery is going to be maybe 4 months later, or is it closer to date of surgery?
You can go ahead and enter those. That's fine.
And then last question for uploading images, do you want just plain images or should we be putting our surgical measurements or pre-op measurements on those images as well?
Again, I would say you're presenting the case to 2 orthopedic surgeons. So I think if that's part of your preoperative routine, it would be reasonable to upload images that have preoperative planning information on them.
Thank you very much.
Dr. Denard? Anthony Denard?
Oh, there you go. Can you hear me?
Yes.
Got it.
Oh, sorry. Thanks. Quick question. Thanks for your time. For the ones of us who just started practice, is there a number of cases, like a limit, or that's something that's too low?
There's a 35 case minimum. So you need to complete 35, have 35 cases as primary surgeon in the 6-month time period.
Okay. Sorry, maybe I missed that because I walked away. Thank you.
Dr. Ben Vegnu?
Can you hear me?
Yes.
Great. Thank you so much for your time, everyone. I may have missed this in the beginning, but I didn't participate in last year's boards because of the change of practice. And so in order to indicate that like we are participating this year, do we just, start submitting our PROs or sending out those emails for our patients, or how do we indicate that essentially that we're participating this year? Or is there no indication, you just send the application at the end in your case list?
So you should be able to get to the case list and the application on your dashboard, and you can start submitting cases and start on the application whenever you need to.
Gotcha. Okay. Thank you.
We got that, Denise? Is that correct? Yes.
Perfect.
I
Thank
bet
you.
Denise is looking to make sure that that's available on your dashboard.
Yeah, please. Thanks.
Is it? It's available, Denise?
It is, and if you will click on the scribe, once you log in with your username and password, that will populate the pros for you to enter those cases through the pros system.
Perfect. Thank you so much.
You're welcome.
Dr. Corbin?
Yeah, thank you for your time tonight. I just have a quick question about the duration of the privileges we have and if the type of privileges we've had has changed after November 1st. So I started on temporary privileges because my full-time privileges were contingent on employment at the university level. So I started in September, and then I got my full hospital privileges at the end of November. So I started on temporary privileges from September to mid-November, and then was transitioned to full-time privileges at the same institution where I will remain until March of 2026. Is that suitable or acceptable?
Yes, that is, temporary privileges are acceptable.
Yeah, you need to
It's at
have
the
that
same
by,
institution. Yeah.
As long as it was before November 1st, correct?
Yeah. Yeah. Okay, great. Thank you.
Dr. Monier?
Hello, thank you for the webinar. It was very helpful. I have a question about the recent trends in the pass rates. If you look at the exam statistics released by the boards, it looks like the failure rate the past 2 years has been 2 to 4 times higher than years prior to that. Do you guys have any insights into why the failure rate has increased so sharply in prior years?
I would say that we've evaluated that from as many angles as we could come up with, and we feel like the exam has been fair, and this past year was much closer to the average over the past 5 to 8 years. And so for right now, we're continuing to watch that, but I would say our feeling is that the two things that could happen are either that the exam changed or the examinees changed, and it probably is a combination of both of those. So that's why we've tried to make it as transparent a process as possible.
I see. Thank you. And just a quick follow-up to that. Does the board release statistics by subspecialty examiner type?
But we have not done that, no.
Okay, thank you.
Dr. Bussier?
Hi, thanks for the webinar this evening. Just a question regarding follow-up. So like many others on the webinar, I'm in a trauma practice. So trying to find people can be difficult. What does the board see as a reasonable effort to be trying to find patients? Like how, if you're not finding someone within 3 months per se, do we need to keep calling? And then if you know that a patient is going to a different state for their follow-up, do we need to be contacting them to be sending x-rays for follow-up, or is it just people that we see in our clinic?
So to answer the last part first, I would say no. You don't have to contact patients who are being followed up out of state. And for the first part of the question, I think that's an evaluation of your practice, and that would be by the examining orthopedic surgeon. So I think there needs to be a plan for follow-up, I think is how I would look at it. And if you look at the scoring rubric, some of those things are listed there, but that would be evaluated by the examining orthopedic surgeons. And so it would be how your practice functions.
Okay, great. Thank
yeah.
you. And just one other question regarding the 14 days absent from practice. Again, as someone who works weekends pretty regularly, is that 14 business days or 14 consecutive calendar days?
14 consecutive calendar days away from practice.
Awesome. Thank you.
Let's go with Dr. Scala.
Hi, thank you again for the webinar. Question is there absolutely no way to do the promise scores in the office? Like if we printed them out, I have a lot, it's not so much I have a trauma practice. I have a lot of patients that live off the grid where I am, like they deliberately live in a yurt, solar power kind of things. So we have a hard time even getting them to sign up for my chart. They can communicate with us, but I feel like I'd have more success if I gave them something to fill out in clinic.
So the promise evaluations of the promise ratings are not conducive to being on a piece of paper because it's a graduated evaluation. So how you answer one question depends on how you answer the next question, depends on it depends on the next question you get. How you answer that question depends on the next question. What changes the next question you get all the way up until and it's usually between 6 and 9 questions, I believe. So again, I think just do the best you can to get emails for those patients that have them, and they'll get the email about the survey, and if they click, they can go to the survey. So I would just say do the best that you can.
Okay, thanks for the clarification. I understand now as email.
Dr. Birnbaum.
Hi, for large hospital systems that have multiple surgical centers or multiple hospitals, are each of them listed separately?
Go ahead, Denise.
Yes, ma'am.
Yeah, I would say yes.
Okay.
Some of those are now combining privileges, but the answer would be yes. So we get the individuals that are involved in your practice at each of those places.
The letter that you have to provide to verify your hospital privileges with those facilities, it can be one letter as long as all facilities are listed either in the letterhead or in the body of the letter. You can just get one letter if need be for all of the facilities.
And then each of them should be listed as separate drop-down menus when we're entering cases, correct?
Yes.
Yes.
Got it. Thank you.
Dr. Koch.
Hi there, thank you. I just had a question for the providers that have mid-levels, NPs, PAs, that sort of thing. Is it looked upon unfavorably if there are documents along the way that is under their name? For instance, if you saw a patient in clinics, treated them conservatively for a while, had a note documenting decision for surgery, and then history and physicals with the PA, or rounding note with the PA, or at some point follow up with the PA, is that looked upon unfavorably or not?
So again, we're interested in evaluating your practice and how you would present your practice to another orthopedic surgeon. If that's something that you're comfortable with, and that's how your practice runs, I think that's what we're interested in seeing. Man,
Understood.
you can sort of play that out if you're talking to a group of orthopedic surgeons and say, yeah, I never see the patients pre-op or post-op. The PAs handle all that. That's probably doesn't fly very well.
Sure.
If you say, the PA does the bulk of the history and physical, and then I sign off on it, and here's my co-signature right here, and I'm responsible for that. And the PA does the first post-op visit, and I do the second, or however you practice medicine. That's what we want to evaluate. So if you're comfortable with it and can explain that, and it makes sense to another practicing orthopedic surgeon, I think that's fine. I mean, there's very few orthopedic surgeons that don't have APPs involved in their practice in 2024, I would imagine.
Thank you.
Sure.
Dr. Suckery? Sorry if I mispronounced that.
Sukaraya, can you guys hear me?
Yes.
Yes, thank you. I have two questions. My first question is related to the type of license that you have. I'm an international medical graduate, but I've been in practice for 6 years. And I'm on a limited institutional license, which means I can only practice in the state, in this institution, because it's sponsoring me for this license. But within my practice, I have unrestricted and complete admitting and surgical privileges. And I've had those for the past 6 years. Is that acceptable?
So that may be something where you need to call us a couple of I would just ask a couple questions. So you completed an ACGME accredited orthopedic surgery residency?
I did not.
So you did not. So you would then need to go through our academic pathway.
He's already done
Uh,
that.
I've already done that. I just recently passed part 1.
Got it. Okay. So yeah, so then you would submit that licensure and paperwork with that.
Okay. My second question is there any age limit on the cases that we have to start uploading as of next month? I vaguely remember reading something 12, less than 12, over 12. Is there anything like that? Because I have a pediatric practice and many of my patients are under 12.
No, there's no age limit.
No age
In
limit.
either
Okay.
direction.
We don't require the pros email for patients under 12 unless you can get the parents' email address for the pros.
Okay. Okay. Thank you
That's
very much.
You're welcome.
Dr. Savage. Alex Savage, can you hear us?
Hi, yes, are you able to hear me now?
Yes.
Great, thank you. Thanks for the webinar tonight. My question was regarding the application process and the letter indicating our current credentialing and admitting privileges at our institutions. You said that that cannot be the original letter. Is there a time after which or at which you would like us to get that updated letter? Should it be closer to the date of submission for the application, or can that be any time basically from now to then, or any details regarding that?
It has to be within the year 2025.
Okay, understood. Thank you.
Dr. Thorne.
My question was just asked. Thank you very much.
Dr. Nguyen.
Hi, thank you. Two quick questions. My first is if we have a patient that returns to the OR for a complication that happened prior to that January 1st start time, would we then be required to submit all surgical operations as well as documentation from prior to the January 1?
So the short answer is yes, to a certain extent. That is will be covered in the instructions once you start the when you get ready to do the upload process.
Okay, thank you.
Sure.
Dr. Fakhori.
Good evening, ladies and gentlemen. Thank you guys very much for your time. Just to reiterate, one of the topics that keeps getting brought up is between the orthopedic and the neurosurgeon. I'm in a private practice, and it's basically the norm in the community to operate with a neurosurgeon. So I completely understand if we're primary, the case is ours, we'll submit whatever, the proper documentation. But let's say we get called in to be a co-surgeon where you're not primary, the patient is not yours, but you are the only orthopedic spine surgeon and you're operating to assist / be a co-surgeon with this neurosurgeon. Are those cases, would we want those cases to be submitted as well?
So would you be dictating an operative note?
Yes, sir.
Then that would be a case that would be submitted. Denise, correct
Understood.
me if I'm wrong, but that would be a case that would be submitted. If that case were one of the 12 chosen cases, you would want to call
Mhm.
us.
Okay, and then just to kind of take that a step further, now if we're not responsible, and we don't see the patient post-operatively nor obviously preoperatively, that's still okay, but may not be chosen as one of the 12.
Right. I mean, then you would put 0 follow-up, right? Your
Yeah,
follow-up would be right.
correct. All
That
right,
would limit the chance of that case being chosen.
sure, understood. Thank you very much.
Dr. Wells.
Hi, thank you everybody for hosting this evening. I just wanted to inquire regarding, if you're doing locums work or something where you're covering a weekend and then you're not at that hospital for the rest of the time collection period, how should we approach those cases and should we be reporting them versus not? Because obviously we don't have a lot of follow-up with those individuals.
Yeah, yes, you would definitely report those. Yes. Those would be surgical cases within the 6-month time period need to be reported. And then they would be obviously reported without follow-up.
Thank you.
Dr. Lee. Sang-Hun Lee, you to mute yourself.
Including cases and spine practice. So the first situation, endoscopic spine surgery, like discectomy or decompression and the visualization of the endoscopic monitor, that should be included, correct?
Say that again.
The endoscopic spine surgery, discectomy or decompression procedure.
Yes, that would be included for sure.
Okay, and second question, some spine tumor or deformity case, we stage the surgery like several days, a week, or sometimes 24 hours, 48 hours, but that should be included as a single case or separate 2 cases.
Each trip to the operating room is a separate case.
Okay, but same patient, different operative date is a different case, correct?
Yes.
Thank you very much.
Dr. Kinney.
Yes, thank you. For the pro data, what do you do? Say you have an elderly person on call for a hip fracture and they don't use email or they're demented and they don't have the ability to use an email. Is that an automatic opt-out or what do you do in that situation?
So if they have an email, then they would decide whether or not they could, fill out the survey or not. If they don't have an email and a family member doesn't have an email, then that would be an opt-out.
Okay. And one other question. My small hospital group is in a transition area. We don't really have a director of orthopedics yet. We're looking for one. What do you do in that situation? Do you just not put that person listed in your practice with all the other hospital administrators?
Right. You would leave that blank for that hospital.
Okay. Thank you, sir.
Dr. Birnbaum.
Mine was answered already. Thanks.
Dr. Kmitkovsky. Ivan.
Oh, yeah, that's me. Sorry, Kemikovsky. I have a quick question. Thanks for hosting the talk and answering all these questions. Um, my wife is going to give birth in February, and I'm planning to take 10 days off paternity leave, but that's 10 business days. So would that be included into the 14 consecutive days of non-operating? Or no? Denise is shaking her head, so.
I think no. I don't 10.
So it's
10
10 business
days.
days?
No. If you're only going to take 10 days, you might want to rethink that with your wife, though. Just saying.
That's all they give me, so I can't take any more.
It's just 14 consecutive days is the rule.
But so does that include if I'm taking the weekends off? Like it would be 5 business days, or 10 business days that would include weekends, so that would be 14 consecutive days. Does that mean my cases are now back rolled to December 1st?
So if those are days that you're not working that you otherwise normally would be working,
Yeah.
then yes, the answer would be yes.
Okay, and I would just have to email whoever my case coordinator is, I guess.
I'll fix it right
Cindy Park.
now. I'll do it right now for you.
Okay.
What if I choose to in the situation I choose to take less time off, so I avoid that, so I take less than 10 days? How do I go back and
Just email your certification specialist, Kim Grover.
Okay,
I won't fix it right now, and you just email her when you make your decision, okay?
thank you.
You're welcome.
Appreciate it.
Dr. Sertahili?
Hi, thanks, guys. Quick question for those of us that are in predominantly pediatric practice, just to clarify, for patients between 12 and 18 years old, are we getting the patient's email or the parent's email?
That can be either one. We would leave that up to you depending on your evaluation of the patient.
Okay, thank you.
Dr. Huang?
Can you hear me?
Yes, go ahead.
Thank you. Thank you guys for your time. God forbid we fail. When does collection start over again?
It depends a little bit, but basically that would start. So you will be collecting in 25, so we would collect in 26, January to June of 26.
You would have to retroactively get all the PROs from before surgery, or should we keep collecting them until?
No, that second time around, you would not do the patient-reported outcomes.
Okay, understood. Thank you.
Dr. Caballero?
Yeah, thanks. Thanks guys for your time. Regarding the 14 days, is that 14 days without having done an operation or just 14 days not being in the office in the clinic?
14 days away from practice.
Okay, so because there might be periods where I don't operate for 2 weeks potentially, right? But if I'm in practice seeing patients, that doesn't count as the 14 days of.
Right.
Okay.
Right.
Thank you.
Dr. Singh?
Yeah, I have two questions. Thank you. First is I did my ABOS in 2021, and so this is my first and last attempt in 2026.
Is that a question?
Yeah, kind of like 5 years will be off, right? After this, I won't be able to, I have to do ABOS 1 again.
Did you do a fellowship after 21?
Kind of locuming, and I was doing, I was not at a particular hospital for more than 17 months. That's why it was delayed.
Yeah, so 26 would
yes.
be your last opportunity. You could do 25 and 26.
Okay. And second question is in Canada, I'm like in my hospital university area, I'm not even remember one person who's ABOS certified. So how do I find for peer reviews ABO certified people?
So there, number one, obviously a list of people in your practice, and then for the 5 from the drop down menu, you would look for orthopedic surgeons who practice in your particular area or region.
Okay, thank you.
Dr. Tariq.
Hey, thank you so much. I had a two-part question. First, about the hospital affiliations. I think somebody asked earlier about the November deadline. So I'm in private practice, so I'm credentialed at 10 hospitals, some of which is just primarily for call, and we don't operate out of there. But do I need to provide the list for each single hospital at the end? And then would all of them count, even if the credentialing was done after the November 1st deadline?
So that, yes, you need to list all those people, and the answer would be, and all those people for each of those hospitals, and but you have to have a hospital admitting and surgical privilege at least one from November through the end of March.
Okay, perfect.
Yeah.
And the second part, in terms of the partners in your practice, so my partners are osteopathic, so they were never credentialed by ABOS. So would I list them like as like separately, or it would just be like not having partners?
No, there's a place to list your partners. So we want you to list your partners with their email addresses. So,
Okay,
yeah,
perfect.
you would list them there. They would not be in the drop down list of ABOS diplomates, but you would
Oh,
list them as your partners.
okay, perfect. Thank you so much.
Dr. Fisher.
Yeah, quick question. I would love some clarification as to what the ABOS defines as a co-surgeon versus an assisting surgeon. Let's say I have a complicated case, I ask a partner to help, and we do, equal parts of the case, but it's technically my case to begin. How does that viewed?
So that sounds like that would be your case, if you're dictating the operative note.
Okay, thank you.
Dr. Spady. Connor, first name. Just when he's talking, I'll get him right back. Hold on. Let's try again, Connor.
Yeah, can you hear me now?
Yes.
Okay, sorry about that. Thanks for putting this on. My question has been sort of talked about before, but not super specific. Say that the patient's elderly and demented and can't respond to an email or doesn't have an email. We should be asking family members to get an email and they report the promise score, or do we just list them as not having an email?
That's a judgment call. Again, if there's a family member who's close and will be with the individual, and has an email, you could do that. If not, then that would be an opt-out.
Okay, thank you.
Dr. Bonilla.
Hi, thank you. I just wanted to clarify one thing. You said that, in the unfortunate event that someone were to fail, they could use cases from, next year. But just to clarify, the submission date for if you had to submit for another round is at the end of August, but we don't actually find out if we passed until in September. Is that correct?
Yes, we extend that deadline if you're unsuccessful in the
Okay.
examination.
Okay, thank you.
And the final question for the evening will go with Dr. Akpinar.
Yeah, what if your partners are not, what if your partners are in an organization but in a different state? So they don't actually have a medical license in your state of practice, yet those are technically your partners.
So if there's less than 12, you would list those as your partners. If if you have more than 12 on the entire list, then you would list the 12 that are closest and most familiar with your practice.
Even if they don't actually have a medical license in the state you're practicing in, and they don't come to your state to practice, but they're the only partners in your organization. Like
Yeah, I
I
would list those
practice,
as partners. Yeah.
yeah. Okay. Okay.
I think.
One person just did it, then
Question?
this is, yep, this with Dr.
All right.
Nguyen, and then we'll save him for last.
Oh, yes. Can you guys hear me? Thanks for the
Yes.
webinar. This might have been answered already. What are the pros used to pass or not pass you on this exam?
They can be used by the credentials committee in making decisions based on the examination, and they are given you get those as feedback to you. So they do not play necessarily into the oral examination at the time that you're presenting cases.
Okay, but can they be used against you to not pass the oral exam? Or like if there's negative, pros from patients?
So the examiners don't have access to those. They may ask you how you follow up your patients, and do you use a patient reported outcome, and did you get those for that particular patient? So an examiner could ask you about that if those were obtained on that patient. Hope that
Yep.
makes sense. Great.
Yep. So I think that's it. And just a reminder, if you missed it, this is recorded and be up probably tomorrow afternoon. Dr. Martin, any final words?
No, just thank you, everyone. If any questions come up, please don't hesitate to give us a call. And please pay close attention to the information packets, especially when you're uploading your case list and then when you're uploading the documents. And don't wait until the last day. If you wait until the last day, you will likely not complete those tasks. And you need to be responsible for your own documents and images. That's the best advice that I could give. But thank you for your attention, and good evening.